I'd like to call up Dr. Aimable Mbituyumuremyi. Okay, not good. I apologize. I should have asked in advance. He's currently the head of the National Malaria Control Program, Other Parasitic Diseases, and Neglected Tropical Diseases Division within the Rwanda Biomedical Center at the Ministry of Health. Welcome.
Thank you. Good afternoon, everyone. Good afternoon. Great. That's it. It's a pleasure to share with you experience from Rwanda to talk about the impact of expanding community case management all ages. Rwanda is a small country located in the heart of Africa, as you can see from there. Yeah, this is Rwanda, and we have this surface area with around 12 million of population. But when you can see from the administrative organization, we have 4 provinces and Kigali city, making a total of 30 districts. And under the district, we have sectors, we have cells, but importantly, we have villages where we have community health workers dedicated to diagnose and manage malaria at household level. That's why in Rwanda we called it home-based management of malaria, but it's the same as community case management. When we look at the epidemiology of malaria in Rwanda, everyone can see that from 2010, there was a decrease in malaria incidence because of key interventions. But from 2013 up to 2016, something happened. And you can see that malaria incidence increased of more than 4 times. And the country had to put in place Malaria Contingency Plan, MCP. This involves different stakeholders to combine their effort for malaria control, because you could see that malaria is not really an issue of the Ministry of Health, and invited other ministries to join. And those include the Ministry of Education, Ministry of Agriculture, local government as well. But key interventions were proposed to make sure that we manage this malaria upsurge. When you look at malaria cases, you can see that from 2013-2014, the country recorded around 1 million of malaria cases a year. These include both community cases and health facility cases. But you can look at this level. We have recorded around 5 million malaria cases per year, meaning that this was really a special case that needed special attention from all over the country. That's when we started expanding home-based management to all ages to ensure that people get access to early diagnosis and treatment. Even though we had no means for prevention, but at least we could manage malaria cases through community case management. And a few years later, you can see that there is a decrease in malaria cases of around more than 1 million cases from 2016-17. Because of those combined efforts, including IRS, BedNet, but importantly, case management. These are key interventions we are implementing countrywide. The first one is about distributing BedNet and also implementing indoor residual spraying, targeting 12 districts currently. But for the information, around 55% of malaria burden is coming from the two provinces, only east and south of the country, because we have good conditions for mosquitoes there. And with IRS, we are targeting only those high burden districts, though the wish should be to extend more in at least 15 districts. The third one is about malaria case management, implemented at different levels, from community level up to health facility level. And currently we have around 60,000 community case health workers, and we have 4 in each village of the country. SBCC is very key to ensure that people access to services and have enough information. And recently we have introduced new interventions, including mosquito repellent products and rividicide. Today we are sharing just the long journey of the country through case management at community level. And this started some years back in 2004, when it started for only under 5, and this was scaled up to all districts in 2008. And this is using volunteers, community health workers, who are elected by the communities, and they used to call them village doctors. They are not paid for that, but at least they are proud that they are called village doctors. And following this malaria upsurge in 2014, as I said, we had to find another solution through expanding this success in the under 5 to all ages now. And this was piloted first in 3 districts, and you could see that it could work because he had learned this experience with under 5, and people were really committed to seek services at community level. In 2016, following the midterm review with the WHO expert, there was a recommendation to extend this to all ages. And in summary, you can see that these are 3 phases, starting from 2015, it's when we started piloting HBM in adult, and up to 2016, as I said, it was the end of the year. We recommended starting in all ages. This is very important to understand, because when we look at the total malaria cases, from this level 2013-14, the blue color represents the number of cases treated at community level. This was really not enough because it represents only under 5. But from 2016-17, you see that around 50% of all malaria cases are now managed by community health workers, and making around 4 million a year. And 2 million of them are managed by community health workers. And currently with the 2018-19, 57% of people with malaria are now managed at community level. What is the best practice in Rwanda? First, as I said, we have 4 community health workers in each village, and we have all women and men dedicated for that, and they are using their own houses. They don't have special buildings for that. That's why it's called home-based management. And this lady is receiving a case of malaria at home. And also, they educate people on how to detect the source of mosquitoes around, but also how to seek services early. These are key achievements with the malaria contingency plan implemented from 2016, as I said. We have recorded a decrease of more than 50% in severe malaria cases countrywide when you compare 2016 to 2019. Second is that we have reduced mortality due to malaria because of this community case management of more than 50% again when you compare two different periods. And also with early diagnosis and treatment, we are cutting the transmission chain, and also malaria cases are reducing in general from 4.8 million to less than 4 million now. And when you look at the incidence, it is now decreasing slightly, and we hope to see more results very soon. And importantly, as I said, 57% of all cases now are managed by community health workers. But we can imagine the challenges of absorbing more than 57% with the volunteers who are not paid for that. This is how now we analyze data to see the case fatality rate decrease with this contribution of early diagnosis and treatment from 36 per 100,000 cases to 7. I think this is a huge decrease, and this is linked to this early diagnosis and treatment. The last slide is about this graph showing, as I said, severe case and also death due to malaria. And everyone can see that as the proportion of people receiving services at the community increases, also there is a decrease in the total number of severe malaria cases in Rwanda from 17,000 per year to 7,000 per year as we move to 57% of HBM. And it's the same for mortality due to malaria. There was this decrease of deaths from around 700 per year to less than 300 a year with this increase of HBM, as you can see. Lastly, we have some few challenges, of course, and one of them is that we do not have enough adequate fund to sustain prevention, because when you don't prevent, we are creating more workload to community health workers because they may not work for their own families. When you go out with your tool to work for the family, you meet 3 people coming with a fever and you can't move. And I think as a country we need now to find a solution so that we can reduce this burden. Second is that those community health workers, as I said, they are volunteers, yes, and they are using their household, and I think we need also to sustain this system. These are proposed priorities for malaria reduction in Rwanda. We need at least to sustain IRS in at least 12 districts. As I said, 75% of all cases are coming from East, and we need at least to cover all these districts in IRS. And recently, we have started introducing new types of net. These are G2 net from Global Fund and the PBO net from PMI. And through the new net project, we hope to see more impact as they are combined with the IRS. And we need to make sure that HBM is resustained. We need to explore new tools, including larviciding, but also look at cross-border issues so that we can collaborate with other countries. This is the goodbye slide, showing that how we now use data to deploy our interventions. When you look at the red color, it's now where we have the most affected district, as I said, the eastern province and the southern part of the country. It shall have more than 75% of all malaria cases, and we are deploying IRS because we know it has a great impact. And for this year, we are now spraying all 12 districts with the IRS using Fedora Fusion. By the other high burden district, we are now planning to deploy G2net because we are assuming that they also have great impact. The yellow color, it's Kigali City and the North. We are deploying PBOnet with the support from PMI, and the blue zone It's almost safe. We are deploying standard net, and I hope that standard net with the HBM may be enough. This is the end of the presentation, and I thank you very much for your attention, and your question and comment are most welcome. Thank you.
So we do have a few minutes if people have clarifying questions specific to this presentation. And apologies again, the only microphone is on this side.
Thank you very much for your presentation. I would like to know the attrition rate for your community health workers, and based on the fact that they are volunteers and sustainability, and what are the plans of the country to ensure that the 57% that are being seen at the community level are actually sustained in the system, since we are attributing the large decrease of the malaria cases to this home-based management of fever. Thank you.
Currently, we have some community health workers who have spent more than 10 years in this, meaning that they don't really move from this work, even though they are volunteers. And as I said, they are elected by communities, meaning that they are neighbors, they are friends. It's not really easy to find someone living unless it's due to the age. Maybe you can see that in big cities they can move, but in rural areas it works. I think every year we can have like 10 new community health workers to be replaced per health center, catchment area, and these are really few. The national plan to sustain this, it's making sure that at least we introduce one indicator linked to their performance to see that they can be motivated. But from the last 5 years, we have put more effort in gathering all of them through cooperatives. And these cooperatives, mainly they are rice farmers, and they are getting some financial support from the government to ensure that they generate some incomes. These are just a sustainability plan we have, but all other ideas are most welcome to improve this system.
Aimable, thank you very much, Silas Majambere. Nice presentation. You show how the spike went from 2013 to 16, like double the number of cases, and you've made a lot of efforts, but it doesn't seem you really going as fast down as you went fast up. Do you have any speculation on what's happening?
Yeah. Thank you, Silas. It's true that the pace at which malaria increased, it's not the same as the decrease, but of course there's some reason behind. One of the reasons behind was mosquito resistance, and we keep using the same standard net from the last 10 years, meaning that we are not really preventing as we wished. It's just recently that we are introducing G2 net and PBO net, and you can understand that we could not see more result. From 2010, we had been using pyrethroid-based IRS, but because of the same resistance, we had to shift from that class to the expensive one. To bendiocarb, to Acteric, now to Fridora, it's almost 4 times the price. And the source of fund did not increase the same time. And you can say that there was a drop in the IRS coverage. Yet you know that it is the same, the only one with the great impact, but the coverage was low. From 2016 up to recently, the country, through its partners, PMI, Global Fund, we could only spray 5 districts among 15 high-burden districts. It's only recently that we expanded up to 12 districts in this fiscal year starting July, meaning that the effort for prevention was not really enough. I think this is just one reason behind. But from now on, as we have the budget to spray in 12 districts, we can see good results. Yeah, it's another good point. As you could see before 2015, community case management was only for under 5. And as expanded to all ages, there was an increased case detection and proper reporting over the years. And this can also justify this increase from 2015 up to now, because now all community health workers can report on a monthly basis. And I think this is another justification behind.
So go ahead.
Okay.
So this
Thanks.
is going to be the last question. If I can, I see there are a few people. If you don't mind to write down your questions and wait till the end, we'll come back to more questions at the end. But go ahead.
Hi, I'm Laura Steinhardt from CDC. Thanks for a great presentation. It was really striking, the increase in the percentage of cases treated in the communities once it was expanded to all ages. And I'm wondering what sort of efforts Rwanda put in place, I guess, as far as SBC or communicating to the communities that CHWs were available for fever for all ages. Thank you.
As I said, community health workers are based in all villages. And at village level, we have local leaders. And through different platforms, they can meet on a regular basis. They can either meet for social meetings, but also for administrative meetings. And we provide key messages through these different channels. And as I said, also being a neighbor, being a friend, being a family members, it's very easy to communicate that there is now almost a family doctor or a village doctor around. And with the previous experience for under 5, because they are now managing the fever in under 5, they have this trust from the community that they can manage all diseases. But also on a monthly basis, the country organizes what we call community work, and everyone from the young age up to 65, everyone is meeting with others for community work, and it's another way of delivering key messages for malaria prevention, but also informing that people have access to commodities, diagnosis, and treatment.